Hello, dental radiography students. Welcome back. We've had a little time off because we had the midterm exam, and we are ready for the second half of the semester. And we're going to start the second half of the semester with a somewhat challenging lecture. There's a little review in it, but what we're going to talk about is how radiation affects our bodies, the biological effects of radiation, and how we can prevent the harmful effects of radiation. Now, we've talked about this a little bit throughout, kind of a common thread throughout all of our other lectures, but we're going to hit it specifically here and talk about how radiation really hits and can harm our tissues. We're going to put it into perspective of dental radiation and how that affects us versus other types of radiation. And then, of course, how we can prevent the harmful effects of radiation. So a little review first. What is radiation? Now remember, there are three basic types of radiation. There's alpha rays, beta rays, and gamma rays. And here's another diagram. We didn't use this one before, but it's a good diagram of alpha rays being the weakest rays. They can't even go through a piece of paper. Beta rays being a little bit stronger. They could go through a piece of paper but cannot go through skin or tissue. And then gamma rays and X-rays as well can go through not only paper and objects but can go through us, through our skin and tissues, but cannot go through lead. So a little review of that refresher. If you need to go back and watch the videos from week 5, I would encourage you to do that. Radiation injury occurs two ways, and we've already talked about one of the ways, ionization. Again, that'll be a little bit of a review. The other way is through free radical formation. So ionizing radiation, if you remember from our lecture from week 5, is the formation of a positive atom because we've dislodged the negative electron, or we have removed a electron from the orbit of the atom. So once the electron is dislodged from the atom, it interacts with other atoms and can cause further ionization, excitation, which just means an increased energy state, so the cells have more energy, and a breaking of molecular bonds. So again, you can review the ionizing radiation video from week 5 if you need to do that. Here is another diagram, and we've had a couple similar to this, of electromagnetic radiation and the types of radiation and when is it ionizing and when is it not. So if we look at the top of this one here where it says the electromagnetic spectrum, that just means the types of radiation. Notice that on the non-ionizing radiation, again, the increased wavelengths, and we've talked about that before, this is not anything new, that as radiation becomes stronger and more harmful, the length between the wave peaks diminish. So we have the non-ionizing radiation on the left side here with the longer wavelengths of radiation, and the increased energy on the right side that is ionizing radiation, and the shorter distance between the peaks of the waves in the travel of the radiation. Next down we have the types of radiation: extremely low frequency on the left side, radio waves, microwaves, infrared. None of that is ionizing, not harmful to us. Visible light is not until we get into ultraviolet light that starts to become potentially ionizing radiation, and then X-rays and gamma rays. And you can see pictures or illustrations of that below. So mainly two types of radiation that is potentially harmful: medical X-rays and radioactive sources and gamma rays. Now, ionization is not as common as the second mechanism of injury. The second way of getting injured from X-rays is through the formation of free radicals. Free radicals are formed from oxidation, and there are a number of factors that cause that, one of which being X-rays. Free radical formation occurs with X-rays when the X-ray photon ionizes water, so we still have the ionization process happening, but it's ionizing the water in the cell. and that causes free radicals. So think about ionization, and we're going to hit this in just a minute, but think about ionization being less common because you have to hit the target of the middle of a cell in order to cause serious damage. Whereas free radicals is the ionization of the water of the cell, which water makes up 60 to 70% of each cell. And if we ionize that water, it causes free radicals, which is an uncharged or neutral atom or molecule that exists with a single unpaired electron in its outermost shell. So it's highly reactive and unstable. What you should do now is to stop this podcast and watch the video on antioxidants and free radicals that is in the links section of our D2L classroom in week 9. The first video there in week 9. Watch that and then come on back. Welcome back. So as I mentioned before, there are two theories of radiation injury. The direct theory being ionizing radiation, which is less common, where the radiation hits critical areas within a cell and causes damage to that cell immediately. The indirect theory is more common, or indirect way of getting radiation injury is from the formation of free radicals, where the radiation, and again, other things cause this as well, smoking and poor nutrition and other things cause this as well, but we're talking specifically about radiation here, where the radiation penetrates the cell and causes damage to the water in the cell. When the X-ray photon ionizes the water of a cell, forming free radicals. And then those free radicals, if they are not healed, and there is a way of healing them through antioxidants, which you learned about in the video, if they're not healed, then they form toxins that cause cellular damage. Key things to remember here: direct and indirect theory. Direct theory is ionizing radiation, which is less common, where the radiation damages specifically a target zone or target area, the heart, the nucleus of a cell, and causes immediate damage. Not as common as the indirect theory, where the radiation ionizes the water of a cell, and then that ionization of the water of the cell creates free radicals. Those free radicals, if they are not healed by antioxidants, then cause cellular damage because they form toxins. Now, how does this injury happen? What's the sequence of the injury? How much and how fast? How much radiation do we need and how fast the radiation is determines the injury. The more radiation received and the faster the dose rate, the quicker the symptoms are visible. So think about, for example, nuclear power disasters where there's radiation released from nuclear power plants, as in, and some of you may know and some of you may not because it's been a number of years now, I think it's been like 30 years, since the Chernobyl disaster in the Ukraine where the nuclear power plant blew and there were massive doses of radiation released from this power plant, caused death of the people immediately surrounding the power plant, and then as the radiation traveled, depending on how fast it was received to people around and how much they received, caused different cellular damage. So that's one way we can get too much and too fast. Another way is through radiation therapy. If we are undergoing radiation therapy to kill cancer cells, that is a lot of radiation very quickly, and that is also going to be very destructive quickly. The slower we get the radiation and the less amount we get, the better for us. So there are three different concepts here that we need to think about, and here's the terminology. The latent period means the period of time between when we receive the injury and when we show symptoms. Now, during that period, the antioxidants could heal the free radicals and therefore cause healing of our body, and we don't have the damaging effects of the radiation. I always talk about this in my lectures when I'm talking about decay, that there's a constant fight always going on in your mouth between minerals and fluoride and the good things in your mouth that help combat decay, and the bacteria that causes decay, and there's this constant war going on, and we want to make sure that that war is balanced. When there's an imbalance of one or the other, there's too many minerals, we get calculus, too much bacteria, we get decay. Either one of those are a problem. Here we're also talking about the same type of thing with radiation. As long as we are getting a small enough amount of radiation that our body has time to heal itself from that radiation, we won't see the harmful effects of it. And that all happens within the latent period. Now, once we start seeing the harmful effects of the radiation, this is the period of injury. On page 37 of your textbook is where you're going to find this information, and the period of injury is where a variety of cellular injuries may result, including cell death, changes in cell function, breaking or clumping of chromosomes, and so forth in this period of injury. Now, we still can, depending on how bad the injury is, again, can be stopped at that point or repaired at that point. But then we have, after that, is the period of recovery, and so that's when we can be healed. The last period in the sequence of radiation injury is the recovery period. Not all cellular radiation injuries are permanent. So if we are repaired, if those cells can repair, then this is the period of recovery, or the recovery period. So make sure you understand, and that definitely test questions and national board test questions on the sequence of how this happens, which one comes first. We have the latent period first, then the period of injury, then the recovery period. And as your textbook says, most of the damage caused by low-level radiation is repaired within the cells of the body. Now, when it is not repaired, then we have this cumulative effect of unrepaired or repeated radiation that can cause cancer. So the effects of radiation exposure are additive. Unrepaired damage accumulates in the tissues, and this is called the cumulative effect, where we have repeated doses, and it can lead to health problems such as cancer, cataract formation, birth defects, that kind of thing. So at the bottom of page 37, you have this table 4.1, and I've repeated it here in the lecture notes, describing the tissues that are most sensitive to radiation and the radiation effect that can happen. Bone marrow, one of the most sensitive tissues to radiation. If we have too much radiation, it can cause leukemia. Our reproductive cells can cause genetic mutations with too much radiation. Salivary glands, thyroid, and skin can cause carcinoma, which of course is cancer. And then lens of the eye, if we get too much radiation in the lens of the eye, it can cause cataracts. So the determining factor on whether or not we're going to get injury is a number of things, a couple of which we've already stated. The total dose, how much radiation we're getting. Is it a massive dose all at once as in radiation treatment, or is it a little bit as in dental x-rays? The dose rate, how fast we're getting it. Are we getting the radiation over a period of a lifetime, such as going outside and getting radiation from the sun over our lifetime? Or is it massive amounts of radiation all at once? Also, the amount of tissue being irradiated. If we're only irradiating a finger, we certainly will be able to recover from that. It's not going to cause death of our whole body if we're radiating just the finger. If we're radiating the entire body, then that is going to be more damaging. So the amount of tissue being irradiated certainly is a determining factor of the degree of injury. The cell sensitivity. What type of cell are we radiating? Different cells have different sensitivity to radiation. Some are radiation sensitive and some are radio resistant. So we'll talk about the difference in those cells here in just a second. And then the age of the cell. The younger the cell, the more sensitive to radiation. Cells of the embryo are the most sensitive as far as age goes, but as we age, we get less and less sensitive to radiation as we age. So cells that are most sensitive to radiation are young cells, rapidly dividing cells, and non-differentiated cells. Cells that don't really know yet what they are. They're still forming. Now there's two different effects that can happen from radiation. The radiation can either affect us, ourselves, or can affect future generations. Somatic just means that it's damaging the patient. The person receiving the radiation is getting massive doses of radiation. It can cause cancer, leukemia, cataracts within that person. Genetic effects means that it's going to affect future generations, their children, the person getting the radiation, their children, which will then cause birth defects, deformities, cancers in future generations. If you look at this diagram of this dog, and I don't know if it's a very good diagram, but I suppose if you're a visual learner, it certainly can help. Notice that we're talking about the dog at the top there is getting the radiation. On the left side, it is referring to genetic mutation, meaning that that dog with the head still up and proud, that dog does not feel any of the effects of radiation, but their offspring, future generations at the bottom of the diagram there, with the head lowered, means that they're feeling the effects of the radiation that their grandparents or parents received. On the right-hand side there shows the dog is receiving somatic mutation. The same dog feels the effects of that radiation, but future generations do not. Okay, so just make sure you understand the difference between somatic effects being the person getting the radiation feels the damage themselves, and genetic effect is future generations. Biological effects on tissues, again, which cells are sensitive to radiation is what we're talking about here in general on the left-hand side and specific to dentistry on the right-hand side here. Sensitive cells to radiation include the lymphatic system, which of course you know is our immune system, gonads, which is our reproductive system, the embryo, newly forming cells in the uterus, and bone marrow. Hematopoietic tissue, which is blood-forming tissues, have the greatest somatic hazard from x-rays, and there is a cancer risk, especially leukemia, from radiation to those blood-forming cells. Tissues that are specifically sensitive in dentistry would be the thyroid gland, because that's close to the mouth and gets some radiation as we are taking dental x-rays, the lens of the eye, the skin, and bone marrow. And those are all discussed on page 41 in your textbook. Notice also on page 41 when it's talking about the risk and risk estimates, left-hand column, page 41, second paragraph, last sentence. Make sure you know, and this is the part of this lecture that I don't like when we're talking about these things, that we need to keep in perspective the amount of radiation that we are giving to a patient or we are producing from taking dental x-rays is minuscule. So as we're talking about all of these harmful effects of radiation, we really aren't talking about dental x-rays. I mean, yes, dental x-rays cause radiation, and so we have to go through all this and understand radiation as a whole. But radiation from dental x-rays, as this last sentence here says, are not significantly greater than the risks of other everyday activities in modern life. And you'll see that in an article I'm going to point you to in a little bit, and in other things in this lecture here, that is going to emphasize the fact that dental x-rays is minuscule radiation. Taking a set of x-rays is the same amount of radiation as going outside for a day, and most people do not avoid going outside because they're going to get too much radiation. Now, there are some people whose bodies cannot fight the effects of radiation. There is a cellular problem with some patients that do not form the protective layer in their skin that protects them, and that is called XP, and they cannot fight off the effects of radiation, and so they would not go outside into the sun because their risk of getting cancer is much greater since they don't have that chromosome that helps protect them from the radiation. But most people don't avoid going outside just because they're going to get too much radiation. And that's the same amount that we give them from dental x-rays. So it's very, very minuscule. I say that because we're going to talk here real quickly about the symptoms of overexposure. And again, people get freaked out when we talk about this. We are not talking about dental x-rays. On the left-hand side here, not applicable to dentistry, massive doses in a short duration can cause a red rash, vomiting, diarrhea, burns on the skin, birth defects, and can be fatal. Highly unlikely in dentistry would be small doses over a long period of time, hair loss, sterility, brittle nails, dry spotty skin, slow healing process, disturbed thyroid gland, nerve or muscle damage. All of those are very, very unlikely in dentistry. Could potentially happen, and let me give you an example. I worked with an assistant one time who always held the film for every single x-ray she took. She held the film in the patient's mouth when she pushed the exposure button. Now you say, well, how in the world did she do that? Does she have an expanding arm to be able to reach the button on the outside of the wall? No, the button was on a cord that you could actually take off of the wall mount, and it was on a portable cord. So she'd put the film in the patient's mouth, she'd hold it, adjust the PID, and then she'd push the exposure button while she's holding the film in the patient's mouth, and she did that on every single patient, on every single exposure. Talk about, I hate using the S word, but that was stupid. Anyway, after a period of time of doing that, she's going to start feeling the harmful effects of too much radiation, because she is exposing herself to radiation, probably 30 to 40 x-rays a day. Every day that she's working, she certainly could be in this exposure category. Other than that, because you are outside of the radiation as the operator, outside of the 6 feet of the radiation, you are not getting any radiation. This is not a problem for you as the operator, and highly, highly, highly unlikely for the patient. Let's put these critical organs we just talked about into perspective. The thyroid gland, a sensitive tissue to dental x-rays. The average dose of dental radiation is 1/1000th of what it would take to induce thyroid cancer. The patient would have to have 1,000 dental x-rays in one sitting in order to induce thyroid cancer. Bone marrow. It would take 2,000 to 5,000 films to induce leukemia. And skin, 500 films in a 14-day period to induce skin cancer. And the eyes, some scientists are even not considering damage to the eyes from dental x-rays because they get so little of a dose of x-rays that it's minuscule. It's highly, 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 highly unlikely that you would get cataracts from dental x-rays, and so some people won't even be discussing this any longer as a critical organ to radiation. So you can see here that it would take lots and lots and lots and lots and lots of x-rays to induce any of these issues, and we would never do that. So hopefully you're getting the idea here that dental x-rays are safe. We're not scaring you to death by talking about the effects of radiation on our tissues here, because dental x-rays is minuscule. Okay, next what we need to do is go over how radiation is measured. And there are two ways radiation is measured. It's similar to our standard measuring system to measure distance, as in inches, feet, yard, mile, versus the metric system, millimeter, centimeter, so forth. So there's a traditional measuring system and a metric measuring system. The traditional or standard measuring system includes a Roentgen, which is the unit of measurement, a rad, which stands for radiation absorbed dose. It is the acronym for radiation absorbed dose, and this is the unit of absorbed dose, so it's the amount of energy absorbed by the tissue. So a Roentgen is the unit of measurement of radiation. A rad is specific to the amount of radiation or energy absorbed by the tissue. And then a REM, radiation equivalent in man, is the acronym, or REM is the acronym for Roentgen equivalent in man, is specific to the type of radiation. So it is a measurement in relationship to whether or not it's alpha, beta, or gamma radiation. And that'll be explained further and better in one of the videos you're going to watch here in just a second. The other measuring unit is the Sievert, or SI, Sievert system, and this is the equivalent of the metric system, and it uses measurements of columns or kilograms, a gray, and a Sievert. So go ahead and watch the two videos. that are in the links section of D2L. One is on how ionizing radiation is measured, and the other one is the quantities and units of radiation. And then come on back. Hopefully you now understand the measurement systems a little bit better. I wouldn't worry about understanding it completely inside and out. I don't understand it completely inside and out, but do understand that there are two radiation measuring systems, the traditional or standard, and the Sievert. What a Röntgen is, what a rad is, what a REM is, and you also need to know what the maximum accumulated dose is. That is discussed on page 53 in your textbook, and what that is talking about is the maximum amount of radiation that is acceptable for occupational exposure. So right above that, actually, we should probably start with the MPD, maximum permissible dose. This is the maximum amount of radiation that is permissible for occupational exposure for people who are taking x-rays in a calendar quarter or in a year. So in the middle of that paragraph, their second paragraph under maximum permissible dose on page 53, it says that the most recent report in 2003, which obviously isn't recent, states that the current MPD for occupationally exposed persons, or those who work with radiation, so dental radiographers, is 5 REMs per year, which is the same thing as 0.05 sieverts per year. For non-occupational exposure, so that means anybody else, the current MPD is 0.1 REMs per year or 0.001 sieverts per year. You do need to make sure you memorize that. And on all of the tests I've seen so far, ask about that in reference to the traditional or standard measurement. So I would memorize that the MPD, maximum permissible dose, for occupational exposure is 5 REMs per year, or 1.25 REMs in a calendar quarter. Now, when you take that maximum permissible dose, now when we want to look at lifetime amount, so that is the maximum accumulated dose is a lifetime amount that is acceptable for healthcare workers. You get this formula, and you do need to know this formula. This formula is on the National Board exam. It is called the MAD, maximum accumulated dose, is equal to N, and N is the age of the person that we're talking about. So if you're age 30, for example, you would take 30 minus 18, which would be 12, times 5, and that is your maximum accumulated dose that you can get for occupational exposure, total exposure in lifetime. So you definitely need to know this formula for test purposes. Make sure you know the difference between maximum permissible dose and know 5 REMs per year, and the maximum accumulated dose, which is lifetime exposure, and memorize this formula. Maximum accumulated dose equals N minus 18 times 5. Now, the next thing I want you to do is to check out the article called Radiation Dose Comparisons. This is also in your D2L classroom under your links, and there is an article there, and it's really good article. Nothing you need to memorize, but definitely take a look at it, and it gives you a great idea of the amounts of radiation that are typical for different procedures. Talks about what are x-rays and what do they do, measuring radiation dosage, reviews. So this is, again, a really good review for everything that we're talking about here. But in the middle of the page, there's a great table there that talks about the equivalent of different types of radiation and the approximate effective radiation dose. Oh, excuse me a moment while I answer my phone. Okay, I'm back. So sorry. The approximate effective radiation dose. So, for example, on this first one here on abdominal region, computed tomography, CT, of the abdomen and pelvis is 10 millisieverts. What is comparable to natural background radiation is 3 years of background radiation. And the additional lifetime risk of fatal cancer from the examination is low. Now, compared to other ones, if you look at, for example, bone, an X-ray of an extremity, so go down to the next section, radiation X-ray extremity, 0.001 millisievert is comparable to 3 hours of natural background radiation. So that's negligible. That you wouldn't even think about that or worry about that at all. If you look at a chest X-ray, so a computed tomography or a CT of the chest, is 7 millisieverts, which is comparable to 2 years of natural background, and so they consider that low. Now look at dental. Intraoral X-ray, 0.005 millisievert, which is comparable to 1 day of natural background. So negligible. Nothing to be concerned about at all. So an interesting chart there and lots of good information in this article. I would scan over it, read over it, use it as a reminder of most of the information that we've already gone over. A couple more things. Where does natural radiation come from? We have talked about where radiation comes from in regards to X radiation or the types of radiation, gamma, alpha, beta, gamma types of radiation. But where does it come from? Where do we get it when it is natural? Make sure you know the difference between cosmic natural radiation and terrestrial. Cosmic means outer space, sun, moon, stars, outer space, and terrestrial means on the surface of the earth or within the earth. So you'll see those terms as you're reading the textbook. Where does man-made radiation come from? It comes from illuminescent watches or anything that illuminates. That is radiation. Illumination is radiation from TVs. And some of you may not even recognize that that middle thing on the left side here underneath miscellaneous is a TV. That is what that is. It's one of the old TVs many a moon ago when I was a wee one. And from atomic bombs is man-made radiation. In the medical field, we have radiation, all different types of radiation in the medical field, and those are all man-made types of radiation. Now, what percentage do we get of radiation from background and what is medical? If you look at this next figure here, and this was done in 2006, compares the early 1980s, so 35 years ago, at the time of this recording, there was very little occupational exposure to radiation. About 15% was medical, and all the rest of the radiation that we received was background, meaning natural radiation, terrestrial or cosmic radiation, radiation from outer space or from the Earth. Fast forward to 2006, and the background radiation is only 50% now. Almost 50% of the radiation that we receive is medical radiation. So we get a lot more medical radiation now than we ever have before, and of course that's with modern technology. Notice that the occupational dose or occupational amount of radiation hasn't changed hardly at all. Slightly less than it used to be in the early 1980s, but not much at all. So what are some factors affecting exposure potential in dentistry? Well, one is the fact that we use F-speed film, which you know all about now. The faster the speed film, the less radiation exposure needs to happen, the less time exposure that we need. So we turn down the exposure time, the faster the film is. Collimation. Rectangular collimators are better, but again, uncommon as we've talked about before. Long cone versus short cone. A long cone with higher kVps is preferred, and that produces less divergent X-rays. If you look at page 50 in your textbook, figure 5.9 shows you, and they look very similar, but if you look at the right eye, above the right eye, and below the lip there of the radiation on the right side, you can see that the 8-inch PID is exposing more of the face further below the lip line and above the eyebrow than the 16-inch PID. Now that difference isn't a whole lot, and I can't imagine that anybody would choose to have a long cone PID specific for that reason, just to reduce radiation. But I would definitely know that concept, that a longer cone produces a less divergent or a less spread out beam of radiation. Now, another thing we need to talk about is the benefits of radiation versus the risks of something happening that we cannot see or cannot diagnose because we don't have radiation. Does the diagnostic benefit gained outweigh the potential risk of the biological effects? So let's take a pregnant woman, for example. If we have a woman who is pregnant, do we take x-rays on her? Well, if she's coming in for her routine 6-month recall appointment, would we take an FMX or even bite wings just because it's her appointment and it's time to do that? No, we wouldn't. Unless there was reason to do it, we would wait until after she is no longer pregnant. If, however, she came into the office with a very swollen face, a fever, a very sensitive tooth, we know that the tooth is probably infected or abscessed, we absolutely need to take the x-ray so that we can treat that abscess, because the harm to her from having the abscess is certainly much greater than any potential harm of taking an x-ray or two. That is a very important concept to consider, is when we're taking x-rays, does the benefit of taking the x-rays outweigh the risk of the exposure to the radiation? If the answer is yes, then we go ahead and do it. If the answer is no, then we don't. Good thing to keep in mind when we're determining what x-rays, if any, should be taken. So how do we keep ourselves and our patients safe from radiation? Well, first of all, we follow the ALERA principle, which we all know already, as low as reasonably achievable, meaning that we're going to turn down the radiation as low as we possibly can. We're going to do everything that we can do in order to reduce the amount of exposure to the patient. We're also going to effectively prescribe the amount of x-rays that should be taken. We're going to check the medical history, check the dental history, talk to the patient, and then prescribe the correct amount of x-rays. You will find that most offices, unfortunately, do not do this correctly. A dentist must, by law, examine the patient first, at least a precursory or an overview of the patient's medical history, and talk to the patient and determine how many x-rays should be taken before we take any x-rays. What you will find is on a recall appointment, and every 6-month appointment, when a patient comes in for their cleanings, we'll sit them down and we'll just immediately, without even looking at the health history in many cases, just sit down, know that it's a recall appointment, and we have an automatic preset amount of x-rays that is the policy for our office that we do. Typically a set of bite wings, so the 4 bite wings and maybe an upper and lower anterior PA, could be a pano, whatever your office has is the normal. The normal would be a set of bite wings every 6 months. So if we did that routinely without determining what is right for each individual specific patient, we are not doing our patients, we are not following the law, and we certainly are not treating our patients as an individual. We're treating them as if they're the same as everybody else and not determining what is right for each individual patient. We also want proper equipment, filtration, collimation, PID length. The thyroid collar on the lead apron will also help to reduce radiation to our patients. Using fast speed film, which we've already talked about, and make sure you know that using fast speed film can actually reduce the patient's exposure to radiation up to 85%. Now, I'm sure that number comes from comparing A speed film, the slowest, to F speed film, the fastest that we can use now. But still, that is a significant number, 85% reduction in exposure to radiation just by using fastest speed film. Setting the proper KVPs in the MAs will certainly also help to reduce exposure to radiation. Using the automatic cutoff or the timer, so your button, when you push the button, it has to automatically cut off, so that reduces radiation exposure to the patient. Following good techniques, so we have as few of retakes as possible, and proper processing and storing will certainly help to reduce radiation exposure to patients. We won't have to retake x-rays unnecessarily. For us, for the operator, how do we protect us from radiation? We stand 6 feet away from the tube head, period. That's really all you need to do in order to ensure that you're not getting any radiation at all. 6 feet away from the tube head. And even that 6 feet is stretching it. Typically, radiation does not travel more than 2 to 3 feet, but you'll find in all textbooks on test questions, 6 feet is the answer. We are absolutely certain that dental x-rays do not travel further than 6 feet. We can use protective barriers like protective walls, lead-lined walls, and there are actually movable. In the first school I worked at, we had a movable lead wall that we can move in front of operatory to operatory so that we can be sure that the people standing or walking on the other side of that are definitely shielded from any potential radiation exposure. Radiation monitoring means using a dosimeter badge. That badge will absorb any radiation that we're getting. You send it into a company, they develop it and read it and send you back a report to let you know if you're receiving any radiation. Some offices require that as the office policy. It is not law. You do not have to do that. Schools used to have to do that, provide dosimeters for all of their students, but that's no longer required by law, even in schools. And we definitely want to make sure we stay away from leakage radiation. Schools no longer have to provide dosimeters. They used to have to, but they no longer have to provide dosimeters for students. Now, when you look at the dosimeter, or that badge there, basically all it is an x-ray that's put into a holder that you would wear every day for a month or so and then send it into the company. The easier thing to do is to just take an x-ray, clip it to yourself with a paper clip. You could even put it in your pocket because radiation x-ray would go through your uniform clothing. So you could just put it in your pocket, but just make sure you don't leave it in there. You take it out every day and put it back in when you get back to work. But then after a month, develop that x-ray and see if it comes out with any dark radiation exposure areas on it. If so, then you are getting some radiation. And that could be inadvertently, could be from malfunctioning equipment, could be that you're not standing 6 feet away, could be a number of things. But that is a radiation monitoring or a dosimeter badge. We've talked about this before. Remember that the two radiation types or beams that could be harmful to the operator are scatter and secondary radiation. And here's our occupational dose limits. Again, we already talked about this. As just a reminder, the maximum permissible dose, MPD, is 1.25 rems in a quarter or 5 rems in a year. And make sure you know the calculation of the maximum accumulated dose, which is lifetime dose, and memorize that formula. That the maximum accumulated dose, or MAD, is equal to N, which is the age of the person we're talking about, or your age of the operator, minus 18 times 5 rems per year, or times 0.05 sieverts per year. And keep in mind that radiation is cumulative. The radiation that is not healed with antioxidants is cumulative and can certainly cause damage. And again, here's a reminder of the federal and state laws regarding who can take x-rays. The federal law was enacted in 1981 that all states must provide training for any professional that is going to take x-rays. Our California regulation is that any dental assistant, does not have to be a licensed dental assistant or an RDA, just any dental assistant under general supervision can take x-rays if they pass a board-approved program. So not just a test or whatever, but they have to take a class, a program, a board-approved program, and receive their license and post it in the office. And they can take x-rays. And then, of course, everybody, quote-unquote, above that category can do it as well. So an RDA under general supervision, an RDA EF, a hygienist, everybody can take x-rays if they have passed a board-approved program and have received their license, and we're going to post it in the office. And we're done. I know this has been a long one, a lot of information. This is kind of one of the two lectures that I believe to be most challenging, although you may find landmark identification also challenging in a few weeks. But here we are. So your homework is chapters 4 and 5 of the textbook. 4 is all multiple choice, and 5 is true false. A few true false. Again, follow the textbook. Some multiple choice, and then a couple fill in the blanks, which you do need to do. 16 through 20 in chapter 5. It's been fabulous talking to you once again. Have a good night, good afternoon, good morning, good day. Talk to you next time.